بسم الله الرحمن الرحيم. في البداية طبعا أحب أعبر عن شكري وامتناني لأخي الحبيب العزيز دكتور صالح نجا والمجموعة المنظمة هذا المؤتمر العظيم. يعني المحاضرة دي أنا اخترت إن أنا أوجهها very practical lecture for young doctors اللي هم direct contact to our kidney transplant patient. I'm going to give a basic clinical information, but it is at the cutting edge of knowledge. آخر ما وصل إليه علم في management of kidney transplant rejection. I will go directly to the issue. We know that the treatment approach in patients with histologic evidence of acute T-cell mediated rejection is guided predominantly by the histologic severity of rejection. So we have to know the biopsy and feel it by heart to treat the patient properly. For example, in patients with borderline T-cell mediated, there is no consensus regarding optimal management. Some transplant centers don't administer specific treatment, i.e. anti-rejection treatment, as we know, but just augment maintenance immunosuppression treatment. Just you increase the dose of TAC prograph level if it is low, you raise it a little bit. You increase the mycophenolate if it's taking 1 gram, you make it 1.5 grams, and so on. And no anti-rejection treatment. But other centers chose to treat borderline rejection as acute T-cell mediated, as 1A, for example, BAMF 1A, for example, given the observational data showing that a pathologic diagnosis of borderline rejection is associated with adverse clinical and histologic outcome, such as progressive fibrosis and increased risk of subsequent rejection, allograft failure, and patient mortality. So we, our center, for example, we follow this recommendation. But if we come to the higher grade of rejection, we say most patients with BAMF grade 1A, for example, we administer pulse high dose intravenous glucocorticoid. But of course, not big dose. You give it, for example, 3 days rather than 5 days of 300 or 500 instead of 500 milligram daily. Followed by an oral glucocorticoid, we give 40 milligrams, and you gradually decrease the dose to reach the basal steroid. In patients with higher grade, we say grade 1, PAMF 1B, and little or no chronic histological change, which affects the outcome of anti-rejection treatment, and especially those with rejection during the first year post-transplantation. Usually, we give rapid ATG thymoglobulin in addition to pulse glucocorticoid. But also here, the dose of ATG is not that the same dose in patients with higher grade of BAMF rejection. In patients with BAMF grade 2 and 3, in which there is vasculitis V1 and V2 and V3, we administer pulse dose, of course, bigger dose, bigger duration, followed by an oral glucocorticoid, as I said, 40 milligrams, then you decrease 10 milligrams every 5 days till you reach the basal. And you give also ATG, but not as in PAMF 1B, but you give higher dose. Okay, so steroid, pulse steroid, ATG, increase, augment the basal immune suppression. If the patient is unable to receive ATG, we administer alintuzumab. We give, how we give ATG, thymoglobulin, usually it's given in a dose of 1.5 to 3 milligram per kilogram per dose over 1 to 3 days. Or you can give, let us say, total dose of 5 to 10 milligram per kilogram, this in transplant rejection during first year of life. In such patient, methylprednisolone is administered 3 to 5 milligram per kg, maximally 500 milligram per dose. This is given prior to ATG to guard against reaction against this ATG. A typical glucocorticoid tapering would be to start by 40 milligram. After you give the pulses, you go to 40, then you decrease by 10 milligram every 5 days till you reach to the baseline, which is 5 or 7.5 milligram. The total number of doses is determined, as I said, by the severity of BAMF. BAMF 1A, not as BAMF 3. As an example, in patient with BAMF class A2, T-cell mediated, we should give rapid ATG thymoglobin 2.5 milligram daily, for example, for 2 days. And in patient with higher grade, we may give 2 milligram per kg daily for 4 to 5 days, depending upon the response in the serum creatinine. We also, of course, as I said, we adjust the component of the maintenance immune suppression. What about anituzumab? Patient who cannot receive ATG, we give anituzumab as single IV dose. We give 30 milligram just IV once. Such patient who cannot receive ATG include those with a known history of allergic reaction to ATG, such as during induction, you give ATG, the patient should reaction, or you give it previously in an earlier rejection episode and allergic reaction occurs, so you cannot reuse it. Or patient with acute T-cell mediated rejection with white count less than 2,000 or platelet count less than 75,000. This patient have to give anituzumab. We also give anituzumab, not ATG, to patients who have a previous history of significant contact with rabbits, such as those frequently eating rabbit, ingesting rabbit, or breeding a rabbit. They are more susceptible to serum sickness if they were given rabbit ATG in particular. In all patients who are treated with thymoglobulin or anituzumab and high-dose glucocorticoid, of course, we have to give prophylaxis against CMV, prophylaxis against pneumocystis carinii, and prophylaxis against antifungals. We have not to forget this. Even the patient have been given the same medication after transplantation. You have to restart it again. As we know, ATG is a polyclonal immunoglobulin that is prepared by injecting human thymus into rabbit. So we are targeting T cell, but also don't forget this thymus contains also some B cell, some RBCs, some platelets. So sometimes side effect occur. ATG induces T lymphocyte depletion in the peripheral blood primarily by complement-dependent cell lysis. It also contains some B cell, as I said. So B cells will decrease also sometimes some patients. ATG has been used both for prophylaxis, we can give it at induction, as induction therapy, and treatment of acute rejection, T-cell mediated rejection. The reversal rate of acute rejection has been between 75 to 100% in different series. And serum creatinine start to decrease within few days. A direct comparison between rabbit ATG and ADGAM. We know rabbit, you inject thymus into a rabbit. ADGAM, this you inject thymus into horse. This we call ADGAM. They found that the rate of reversal of rejection episode was much higher, significantly higher with a rabbit ATG than in ADGAM. And also, recurrence of rejection episode was more in patients treated by ADGAM than those treated by ATG. So most centers now use rabbit rather than horse ATG. What about anituzumab? It is a humanized anti-CD25 monoclonal antibody that is approved for treatment of chronic lymphocytic leukemia and later on has been approved for treatment of DS, disseminated sclerosis. We know CD52 antigen is present in T lymphocyte B, so it will attack both T and B. And also natural killer cell, and to less extent monocyte macrophage. So it is widespread action. It is strong. And eptizumab lies lymphocyte via complement activation and via antibody-dependent cellular cytotoxicity. The practical advantage with this agent include it is given in a peripheral vein and just it is one dose, 30 milligram. So it is very practical. Also, it has been reported to be successful in treatment of T-cell mediated rejection in pediatrics. After treatment, we monitor the response to therapy. All patients, of course, are admitted. We follow serum creatinine daily. If we go down to 10% above the baseline, we say the treatment is successful. But failure to achieve this, we may say failure of treatment, and we have to go to the next steps. In such a patient who fail to respond, either it is an ongoing rejection and or another cause of renal allograft dysfunction should be suspected. For example, CMV, glomerulonephritis, for example, or ATG, or another thing, or antibody-mediated. Our subsequent approach depends upon the initial treatment of rejection. This is very practical, since sometimes we face patients like this. What to do? This slide is busy, but it will explain what to do in your round. In patients who have been treated with glucocorticoid only, we administer ATG, easy. In those patients who cannot receive ATG, you give alintuzumab. And if not available, you can use ATGAM. In patients who have been treated by ATG or alintuzumab, what to do? So you have to do rebiopsy, since this is the most potent treatment you have in your hand. Do biopsy to exclude alternative diagnosis or more severe histologic lesion. You treat it as BAMF 1A, and it is now BAMF 2 or 3. So you give more potent. Or it came as antibody-mediated rejection, so or mixed rejection. So you have to switch to antibody-mediated, which I'm going to explain now. Okay. If you found a much irreversible tissue, much fibrosis, you will stop anti-rejection treatment. When to stop treatment, I will leave this issue for my colleague, Dr. Mohamed Sobh. This is the title of his lecture. Now we come to the other category of rejection, which is treatment of active antibody-mediated. The primary goal of treatment of antibody-mediated rejection is to remove existing donor DSA in the circulation by plasma exchange, and to eradicate the clonal population of B cell and plasma cell that is responsible for their production. Our approach to the initial treatment of active antibody-mediated rejection is how much? In patients who are diagnosed with antibody-mediated within first year post-transplantation, we treat with combination of glucocorticoid plus plasmapheresis plus IVIG. And in some patients with peritoneal capillaritis, we may give rituximab. So these are the treatments to be given. We give IV methylprednisolone, as I said before, and we augment the basal immune suppression. We give IV methylprednisolone in a dose. Okay, I said this. It is not working. Computer is not working, please. طبعا انت هتحسب الوقت ده؟ لا 5 دقايق. طيب ماشي. طب معاك كلام من بعيد. طب ماشي اقلب بيه. طب فين بقى؟ ده يعني ده كده كده كده. طب دي كده. اوكي. What about plasmapheresis? is performed daily or better every other day. Why? But for a maximum of 6 sessions. Some center will continue till creatinine go down. Of course, we make 6 sessions only, but on alternate day. The initial treatment is typically 1.5, 1.5 volume exchange with albumin, not plasma. And subsequent treatment are 1 volume exchange with albumin. We prefer an every other day plasma pheresis schedule, as albumin alone can often be administered for replacement with interval recovery of prostrone. You give 2 days so that you remove prostrone and clotting factor. These 2 days will allow for regeneration. But sometimes the last 1 or 2 sessions you may give fresh frozen plasma in certain setting. For example, if the patient need biopsy, for example. Okay. We administer IVIG as a dose of 100 milligram per kg after each session plasma pheresis. Of course, after, not before. Otherwise, it will be removed with plasma exchange. So steroid before plasma, then you give plasma, then IVIG. 6 dose. In obese patient, some center determines the IV dose based upon patient ideal body weight. Of course, you have to use sucrose-free IVIG solutions that are no more than 5% concentrated. This is preferred to avoid acute renal injury. Sometimes this IVIG can cause ATN. So take care from the concentration. In patients with evidence of microvascular inflammation, so look to the biopsy well and read what about the peritubercular capillaritis. If it is there, you can give plasma rituximab, 1 dose of rituximab, after completion of plasmapheresis and IVIG. In addition, of course, as I said, we augment the maintenance immune suppression. In patients who are diagnosed with active antibody after first year, this is another issue. We treat with glucocorticoid using the same approach as I said before. However, we don't perform plasma pheresis in such patients because the lack of evidence supporting the safety and efficacy of plasma pheresis after innate antibody-mediated rejection. And how we give IVIG? How we give IVIG? Here we give 200 milligram, but every other week. Okay, so it is the same amount, but instead of giving in 6 days, we give 200 every other week, so it's the same amount. So steroid, IVIG, no plasma exchange, and you can give rituximab if there is peritubular capillaritis. In all patients who are treated for active antibody-mediated, we recommend, of course, the same. Give prophylaxis against CMV, against fungus infection, against pneumocystis carinea. What about if the antibody-mediated rejection, we fail in treatment? What is the second line? In those patients, we give bortezomib. Bortezomib is a potent, reversible proteasome inhibitor that has been approved by USA FDA approved as a first line treatment of multiple myeloma. انت ما حسبتش الوقت اللي انت ضيعته. اشتغل. That is bortezomib. Okay. Now, okay. How it's given? We need 2 cycles. الدوز بتاعت البورتيزomib 1.3 ملي جرام بير سكوير متر سيرفيس اريا بتتعاطى في day 1, 4, 8 and 11. Eculizumab, very expensive drug. Okay, it is a second line, third line of treatment. Has been approved in many purposes other than antibody mediated. What about patient with mixed? You treat both antibody mediated and T-cell mediated. You give 5 agents. Patient with C4D negative, treat him as C4D positive antibody mediated rejection. patient with non-HLA DSA, the same, treat him as antibody mediated. For patient with antibody against angiotensin 2 receptor, he will be
Dear
severely
doctor,
hypertensive, so
your
give
time is
ACE,
up.
anti-ACE. Okay, and just two slide or one slide, I can say it. So now we know antibody mediated first year, antibody mediated rejection. After 1 year, the treatment is different. Then we come to the chronic antibody mediated rejection. Very simple notion. Treat him as antibody mediated rejection after 1 year post transplantation, and thank you.